We have time for the speakers for question and answers. And I actually was very interested to hear from Dr. Orlowski as he went over the different menus of salvage therapies. Do you think we're going to be using the salvage again as frontline and then losing them for the possibility of salvage therapy? Is that going to be the model?
I think that's a good question. Of course, it depends on what kind of response duration was seen the first time around, because there are nice data about retreatment with bortezomib as well as retreatment with IMiDs from the folks at the Mayo Clinic. So if you have somebody who tolerated the combination well and in my mind had at least a 12-month benefit and their relapse is off of therapy, I think going back to that before you burn another bridge, if you will, is probably the best approach right now. But as I mentioned from the laboratory data, hopefully we'll be at a point where we'll be able to identify which patients relapse with sensitive disease to either a proteasome inhibitor or an IMiD, and which ones have insensitive disease, and the sensitive patients you would retreat. The insensitive patients you would hopefully retreat, but with another drug to try to enhance sensitivity.
So, well, to Dr. Fonseca, Dr. Chung, and Dr. Chim, we know our audience here was not doing FISH and cytogenetics. Do you think outside of gene expression profiling, or even with gene expression profiling, with any of, is there any technique we should be eliminating now in the work of myeloma, or are they all informative? So we're actually going to have to do FISH, cytogenetics, and soon gene expression profiling.
I can maybe start with that. I would say the first one I would eliminate is karyotype analysis, because it's as expensive as FISH or gene expression, and it has a very low yield. It's like sending your patients for an X-ray and getting a report back in 10% of the time. So that's my view on cytogenetics. I'd probably eliminate flow cytometry. It's really of minimal to trivial relevance in myeloma, unless we start testing for things like FGFR3 or CD20 or some other things. So again, with the caveat that I'm very closely related to FISH, I would say probably do that. And if you want to save money, just don't do flow cytometry or anything else.
Dr. Chung and Dr. Chim, would you care to comment?
I would agree with that to a certain extent, in the sense that, I think one of the questions we ask is, how much does this information actually change our management, right? But I think in a lot of our countries where the resource may be limited, we want to restrict the use of expensive drugs, maybe, to rationalize the use of those to subgroup of patients. Then we certainly need to have some guidance as to who are the high-risk patients that will derive, more benefit from these treatments. So I think FISH will be useful, and if we want to limit the cost just to the high-risk FISH, like the 414 and 17p, so limit the panel size. In regards to the flow, I think the utility in diagnosis may be limited, but I think with the emerging data of the importance of minimal residual disease, it may still have a role in the future. James?
I think, actually, to me, I think, of course, migration has got a role in terms of understanding the pathogenesis and also progression of disease. And I believe that it might also have a role if we can validate prospectively in large number of patients the role of gene or microRNA methylation in the outcome of patient in uniformly treated cohort of patients. So that's why in Hong Kong, actually, we established the Hong Kong Society of Myeloma with a view that we can actually align the treatment protocol, and hopefully we can collect samples from the patients at the time of diagnosis or plus or minus relapse. Hopefully we can actually translate the implication or impact of gene methylation in terms of outcome protection. And the other thing that I might think of is actually, I'm not sure, because there are a lot of clinical people here, experienced people here, so I just wonder whether actually PET-CT scan should be done at the time of diagnosis as a predictive factor for, say, for example, to predict outcome, and also as a monitoring tool, say, and also is, for example, at the time of remission. So actually we have been arguing a lot about the definition of CR. So obviously the hematological or biochemical the definition of absence or reduction of protein to negativity does not really mean that the patient is actually having no residual disease. On the other hand, I'm sure that most of you have the experience that some of the patients at the time of relapse, they actually have got a light chain escape, meaning that initially they may have an intact immunoglobulin at the time of relapse. Actually, they may masquerade. They have a CR, but actually they have converted to a light chain secretory disease. So or even non-secretory disease. So I think I just wonder whether the PET scan or some kind of imaging might also predict or actually is a better tool to help us to monitor disease remission status or even disease progression. So I'll be very glad to hear opinions from both on the stage and also from the floor.
I think that's going to probably have to wait for the next session. Dr. Coleman, if you care to close the session for us.
Much. I just want to ask a very provocative question. Suppose you have a good prognosis, so be the intermediate prognosis patient who, with your induction therapy, regardless of what it is, gets a strict complete remission, albeit maybe will one day be able to get a molecular complete remission. Does that patient need a transplant? And secondly, Dr. Chim, what does CREB do? I noticed it was a product, but I was wondering what that did, and then perhaps maybe we'll have them answer the other questions. And I agree with you, by the way, PET scans and MRIs are extremely useful in staging and following patients with myeloma.
So I think we'll go start with, I was going to ask you if we can defer the transplant question to the next session. Okay, and I'm going to ask...
but then we can't hear your opinion on that.
You will hear my opinion on that.
Sergio, can I close?
I will actually always remind people that transplant is a choice. It's not a necessity, okay? It's a choice patients make based on recommendations that the physicians give them based on our perception of the natural history of the disease. We need water, we need food, we need love, we need air, we don't need a transplant.
Sergio, there's another question here. I don't know if you want to take it, but I think Dr. Orlowski got the message that a good shave early in the week sort of carries the day, so I still need to update this picture.
Yeah, Jeffrey from Taiwan. One question for the Dr. Orlowski. So really thank you for excellent talk every time. So you give you a long list of the salvage regimen for the patient with relapse and refractory. My question is for the extramedullary diseases. So what's the best or the better regimen for the patients to even at the time of the extramedullary diseases?
Yeah, it's a good question, and probably everybody on the panel could answer that, and maybe the answers would be different because I don't think that we have enough experience to be able to say that one regimen versus another is better. I think for patients who present with extramedullary disease later in the course, where it seems to be a more aggressive phenomenon clinically, I usually try to go with a multi-agent chemotherapy combination, including some cytotoxics, whether it be DT-PACE or whether it be modified CVAD. But I don't know whether that's better than anything else, and maybe that would be a good topic for discussion.
Yeah, I mean, for my practice, we do see more patients. I think that's where Jeffrey's question is coming from in Asia, where perhaps their initial presentation is with extramedullary disease. And so my approach has been, along the lines of using combination chemotherapy, get them, because most of the novel agents actually do not have good penetrance to these extramedullary sites. So you may clear the marrow disease, but the extramedullary tumor is still around. So I would approach with combination chemotherapy. If they're transplantable age, I'll do the transplant and then try to maintain them, because in my experience, these are more likely to relapse patients as well.
Actually, I got experience that one of my patients, my first experience with bortezomib is actually at the end of 2004 when I had a patient with primary extramedullary plasmacytoma that basically behaved as a chemorefractory plasmacytoma. So it's almost like a lymphoma. There's an entirely chemorefractory. At that time, actually, the patient has got a lot of B symptoms, fever, very poor nutrition status, and she's got plasmacytoma both in the mediastinum, the soft tissue, and even in the pancreas. At the time, we try actually a lot of chemotherapy, CHOP, DHIAP, and then we go back to melphalan. All of them doesn't work, and thalidomide, all of them doesn't work. And then eventually we grab bortezomib, just one cycle of bortezomib, that the patient went into complete remission. All the soft tissue are gone, fever resolved, and the patient pick up on nutrition. Even the CT scan on the pancreas has gone into complete remission. So I think regarding that, in my limited experience, because we may have some disparity in terms of frequency of extramedullary disease, but I don't see very often extramedullary disease at the time of diagnosis. But apparently, even for that, I think the novel agents targeted therapy appears to work very well. Actually, we published that in the JCO as a case in General Clinical Oncology in 2005. And obviously, I think the question is if they have extramedullary disease, I think radiotherapy is definitely a very good option. It depends on where the disease is, and actually, if you start treatment, how well it responds, and whether you want to use radiotherapy as an urgent induction therapy, part of an urgent induction, if this is in the closing cord compression, or actually as a kind of consolidation after the patient went to remission. So I believe that radiotherapy is definitely an option.
So I want to thank Dr. George, who chaired the session with me, as well to all our speakers in the audience. We have a 10-minute coffee break. Thank you very much.
Thank you.